All right. I think we are going to go ahead and get started. We've got several people here. There may be others that still join the Zoom. But we're really excited you're joining us today. My name is Chris DeGree Kennedy. I'm the president of the Bell Policy Center, and I'm so excited that we're unveiling to you today our home care cost model that we've been working on in collaboration with Tri-County Health, as well as the Colorado Latino Leadership Advocacy and Research Organization of Colorado. So by way of introduction, before I hand it over to our outstanding policy analyst, Perrine Monnet, I want to just set the stage. So as many of you already know, Colorado is one of the fastest aging states in the country, and a very significant number of older adults are going to need in-home care at some point in time, and many prefer to age in their own homes. As such, the need for in-home care is growing and growing, and it becomes more and more important that we support paid and unpaid caregiving. However, our understanding of what it truly costs to provide in-home care has been limited. This has prevented us from fully supporting caregivers and those they care for. The Bell, together with Tri-County Health and Claro, has built a home care cost model to quantify the cost of providing in-home non-medical care to older adults in the state. So with that, I'd like to introduce Perrine Monnet, our policy analyst who has led the development of the project and spent more than a year on this research project putting together this incredibly important tool. Perrine?
Thank you, Chris. And we can go to the next slide to get us started. Just quickly, we'll take some time to go over the model. We'll walk through a couple sample scenarios to help sort of explain and demonstrate how the model can be used in different ways. We'll go over a few takeaways. Amy, who are here again from Claro and the Tri-County Health Network, to talk a little bit more about caregiving and what that looks like across the state before we wrap up. And so on the next slide, just to get us started, and I should also add actually that in addition to Tri-County Health Network and Claro, so many partners helped us along the way, thinking about what needed to be included in the model, what sort of helped guide this model and provided feedback and helped with survey distribution earlier in the process. And so thank you all, and we're really excited to share the model. But so Chris gave a nice introduction, and as many of us already know on this call, supporting in-home caregiving for older adults is critical. So in order to do so, we wanted to look at how much does it actually cost. And so the model doesn't just look at the current costs of providing care, but what we are calling the true cost of providing care. And so that includes supporting paid caregivers with different wage scales, a living wage, a robust benefit package. It includes costs like overhead, administrative costs. It includes turnover costs, so costs that an agency might typically bear in providing care. But it also includes costs associated with unpaid care. So thinking about lost wages that family members and friends might experience who have to step away from the workforce in order to provide care for a loved one. There are out-of-pocket equipment costs that are important to caregivers, and also thinking about health impacts to the caregiver. And so these are some costs that we were able to include in the cost model and is included in sort of what we are calling this true cost of care. And really this helps us understand what does it look like if we were to more adequately support and invest caregiving. The model importantly makes these projections at the county level as well. So it will allow us to look at statewide information, but also look at more specific county by county projections. And then in a second here, we will, on the next slide, actually, you'll see that the user is able to change certain parameters to fit the user's need and what you are looking to get from the model. So on the next slide, this is just a screenshot of what the model looks like, but Andrea will be sharing a link in the chat. So please feel free to go to that link and take a look at the dashboard and its interactivity. But this is what it will look like. This is what it looks like. And Boulder Insight, another great partner that we worked with to help visualize this and create this dashboard and take all of our work that we did to create it into this user-friendly format. So you'll see on the left-hand side that there are some adjustable parameters. So here you can make different assumptions, again, based on what you are hoping to answer, what you're looking for in terms of county specifics, if you're looking at a specific population that you'd like to know more about. And then one thing that's really great about this is looking at the wage type. So you have 3 different options. You can look at current wages that we're paying personal care aides, for example, but you also have the option to increase that to a self-sufficiency wage or a housing wage and see how those costs might differ. Similarly with the benefits, we have the more like a current, what is just required in terms of benefits by state law, and then also a more sort of robust required and preferred benefit package, which includes things like health insurance or paid time off. And I know Andrea's sharing some links to some briefs that we have written about this model, and that will go into a little bit more detail about sort of what is included in each of these things and what sort of data we're talking about with each of these. But you'll also see that you can change the percent of care that is being provided, whether it's provided by paid care, so through a more maybe more traditional like agency model, how much care is being provided through the CDOS model, the Consumer Direct Attendant Support Services, and then the percentage of care that is being met by unpaid caregiving. So thinking again about those family and friends who might be stepping in to provide care. And then on the right-hand side is where you'll see the outputs and sort of the total cost that's then broken down by each of the care types. And then more specifically in unpaid care, you see that breakdown of what is driving the cost of unpaid care, whether it's those lost wages, the health impacts, et cetera. And I'll also just note, hopefully as you all are, looking at the dashboard, please feel free to mess around with it as we go through these and follow along even with some of these sample scenarios. But we will also be coming out with like a little tutorial video. So if you ever have any questions or very specific questions about interacting with the model, please feel free to follow up in an email or just know that we will be sending out a tutorial video as well on the exact interactions of these things. But on the next slide, we will go over a few sample scenarios just to help demonstrate the ways in which these parameters can be adjusted depending on what you might be interested in looking at, and hopefully just helps get a better idea as to how this model can be used. And these slides will also be posted and shared, so you can always refer back to these sample scenarios as well. On the next slide, the first scenario that I thought would be important to go over is thinking about the more robust support for paid caregivers. We know that paid caregivers, receive too low of wages. They have often few workplace benefits. And as Chris mentioned earlier, with a growing population of older adults who will prefer in-home care, it is important that we address this as it has led to high turnover, recruitment challenges. And so we want to know how much would it cost if we were to adequately support, adequately invest, and pay caregivers a living wage. So currently, we know that about 80% of care is provided by unpaid caregivers. However, in this analysis, you'll see that we've increased the wage type to a self-sufficient wage, and that required and preferred that more robust benefit package in order to support caregivers. But that's not the only thing that this scenario adjusts. We also adjusted the percentage of care. So although we know that 80% of care is currently being provided by unpaid care, under this analysis and assumption that of paying higher wages, offering benefits, it's likely that we would see maybe some increases in the amount of paid care that is being provided. And so you can change those parameters. We increased paid care to 25%, CDOS is at 5%, and then the percent of unpaid care was at reduced a bit to 70% from that 80% number that we know is currently happening. And you'll see that the cost, of course, will certainly increase by implementing higher wages, by implementing a more robust benefit, and also having more paid caregivers. We will see those costs increase. But I think importantly, what this does is gives us sort of a better understanding of where we're at now and where we need to go in order to be supporting paid caregivers in this specific way with wages and benefits. On the next slide, the model also can be used to answer questions or to better understand caregiving for specific types of care or for different care needs. In this sample scenario, we chose cognitive impairment. So for example, it could be interesting to look at this population if you're wanting to understand how costs might look different for someone caring for someone with dementia, for example. And you'll see on the model that there are a few different options, of course, in terms of the population. And the main scenario highlights that I would point out is importantly, we increased that FTE per care recipient, and that is the amount of hours of needed care. And so that is increased to 100%, or the equivalent of 40 hours a week. And that is because we know that often people who are caring for someone with dementia, for example, often need increased amount of care. And so that is why we increase the amount of hours needed. And then we also, because there are more hours of care that need to be provided in this scenario, we might see an increased help coming from paid care. So shifting that also to 25%, perhaps there would be a slight decrease in the amount of unpaid care. However, that 70% still represents a larger amount of hours being provided by unpaid caregivers in this specific scenario. And then another thing that I would highlight in this scenario is at the bottom, you will see there are 4 sort of additional trainings or things that a user could select to include or exclude. And this one, we included a dementia-specific training. And this really came from partners in the space where, if having a dementia-specific training for the caregivers who are providing care for someone with dementia would be beneficial for many reasons. One, for the caregiver, but also to ensure that people are receiving the appropriate care and that the caregivers have the appropriate resources in order to provide that care. So this is a good example of how you might not only be changing the population of care, but along that, it's important to change other parameters accordingly based on the population that you are looking at. And then on the next slide, Alicia, thank you. The model can be used to look at different counties, different areas of the state. And so this scenario, it would be an example if you were interested in understanding caregiving in rural areas. And so what we heard a lot throughout this process, and with a lot of the conversations with the Tri-County Health Network, and we had focus groups as well throughout this process with folks in rural areas to understand sort of what does caregiving look like? How are people accessing care? And what we heard was that there was really just a lack of paid care in rural areas. And access to paid in-home caregiving is very limited. And so here, you might pick, of course, whatever county accordingly. In this example, it's San Miguel County, but any sort of rural county that you're interested in looking at. But importantly, the main changes are looking at the percent of care that is being provided by paid or unpaid care and CDOS. So here, paid care is a much lower percentage. It is only covering about 5% of the needed care. And CDOS and unpaid care both increase. So we have CDOS increased to 10% of the care that's being provided and unpaid care at 85%. And I think here, especially in areas where there is a severe lack of paid care, that often means that family and friends are the ones that need to step in to help provide that care. But CDOS is also an especially important program as a way for people to receive care in areas where, again, that paid care in a more traditional agency setting is more difficult to find and access. And this is also, the scenario also allows you to look at how different counties might experience these costs differently, sort of how the costs might be distributed differently based on the county, if it's an urban county, a rural county, for example, just how these costs of care are redistributed among unpaid caregivers or paid care, et cetera. And then we can go to the next slide for another sample scenario here for supporting unpaid caregiving. And I would say, you know, as I mentioned earlier, one thing we really wanted to do with this model was to acknowledge that unpaid caregiving is extremely important and valuable, especially as many people actually prefer to receive care from a loved one. And so while there are ways that we should absolutely, you know, increase retention and recruitment for paid caregiving and ensure that that option is available for folks who want it, it is also important that we acknowledge that unpaid caregiving is valuable and also needs support. So this scenario is really just helpful to highlight some, again, these additional trainings that are available on this, these adjustable parameters. So again, this was identified through our surveys. We surveyed many unpaid caregivers. And one of the most common sort of supports that were requested or noted throughout these surveys was in learning how to better care for themselves while caring for a loved one, or learning how to more appropriately set certain boundaries while they're caring for a loved one. And so here would be an option to include that self-care for unpaid care, to sort of apply this additional cost of what would it look like to provide resources for unpaid caregivers in order to do so. And looking, I would also note that as you look at these outcomes, when we think about supporting unpaid caregivers, looking at the cost drivers of unpaid care and looking at what is really pushing those costs up and seeing where the greatest impact might be for support, whether it's looking at the health impacts or is it looking at some workplace policies and things like that. And then quickly on this last slide, on the next slide, I just wanted to highlight another sort of scenario looking at these population differences just based on some questions that we've received. And this is just to sort of highlight how so the self-care limitation is different. So up until now, the broader category that we've been looking at in these sample scenarios was those who are likely in need of direct care now. So that's including people who need assistance with an activity of daily living or an instrumental activity of daily living, and may include a population of folks who might need less frequent care or fewer hours of care. And the self-care limitation is sort of like a subgroup of that population, or a more narrow group of that population who have a self-care limitation. And this ends up being about 7% on average of older adults who have a self-care limitation, and may indicate that there is a higher need for care. So in this scenario, you change the population of care that you are looking at. And I should note that all of the population specifics are for older adults, so 65 and older, and who have a self-care limitation, a cognitive impairment, et cetera. But so we also increase that hours of needed care, that FTE per care recipient. So just another example to sort of highlight, as you change the population, you'll want to also think about how we might change the hours of needed care and how that care is being provided. And of course, also just want to highlight that these are meant to help you all understand and think about other ways that you might want to change these assumptions for specific groups of older adults or different scenarios. And of course, there are many, many scenarios that you could all look through. And this is also hopefully something that will be continued to be updated over time as we get more data, better data, feedback from our partners who are using the model, and thinking about other population specifics that would be helpful to include, and other sort of parameters that might be helpful to include in this model. This model we hope will continue to be updated as we get more and better data. So on the next slide, I will just briefly go over some main takeaways so far. So we did do some analysis that incorporated various of these sort of scenario recommendations or sample analyses, which I think Andrea will share in the chat. But ultimately, what we have found so far by using this model is that our current public investments are far from adequately supporting paid or unpaid caregivers. The investments that we make in unpaid caregiving are limited, and as you'll see when using the model, the costs are really quite high for unpaid caregivers. And when we think about paid caregiving, an hour of paid care with a self-sufficient wage is looking like on average over $20 more expense or more than the hourly Medicaid reimbursement rate that we're currently providing. And so, this is when we think about this sort of public investment, we have certainly some work to do, and we hope that the model can help guide some of that progress and help us see where some of that can be most effective. The second being that when we think about these public investments, it is important to have a targeted approach regionally or by county, and understanding that different areas across the state are experiencing care very differently and may require different support. Understanding how the costs of care differ by county. So the model also includes transportation as a cost that's included. So how do we see these impacting the cost in different counties, and how might we better target our support for these areas? And then finally, related to that is how can we support multiple forms of providing care? So not only supporting paid caregivers, but ensuring that we continue to support and center unpaid caregivers. How can CDOS as a sort of delivery method of care also be an important program, as it shows to have some cost savings compared to paid care, but is also a really important mechanism of providing care, again, in rural areas, for example, and is an important way that family members may be able to receive compensation for providing that care. And we will sort of continue to do future analysis with this model. We're really excited. This is only very recently completed, so we have a lot we want to continue exploring with this model. And we hope that it's a tool for you all to continue asking and answering questions about in-home care for older adults. And we're looking forward to hearing your feedback as well as you start to use the model. And I will stop there for now, but I know we're continuing some of this conversation with some great panelists.
Thank you so much, Perrine. That's a wonderful presentation, and a lot of exciting potential for what we're going to be able to do with this research. So as we move into the next part of this discussion, I want to go ahead and introduce our other two panelists. And actually, I'll just call them out and then let them introduce themselves. But let's start with Amy Rowan from Tri-County Health Network.
Hi, everyone. Thanks, Chris. Thanks, Perrine. So excited about this process. I'm Amy Rowan. I'm one of the co-executive directors at Tri-County Health Network. Our main office is in Telluride, but we also have an office in Delta, Montrose, and the west end of Montrose County. We provide quite a bit of care coordination, and so it's been great to walk through this process. We work with a lot of caregivers in our rural and frontier areas. So we see a lot of the struggles that people are having, and we see, a lot of people thinking outside the box trying to get care. So thank you.
Thank you. And next, I'd like to introduce, and we'll promote to a featured panelist, Mia Villa from Claro. Mia?
Hi, my name is Mia. I use she, her, ella pronouns, and I am a research associate at Claro. And I want to thank Bell Policy for having me as a panelist today, and for the research team at Claro for allowing me to represent them today. A little bit about my organization. Our purpose is to empower Latinas through leadership development, advocacy, and policy research to strengthen Colorado and really create a state where Latinas can thrive and reach their fullest potential. Something that we do is run an older adult social group made up of older Latinas, where in the past couple of months, we have intentionally created a space for them to really connect with peers of similar ages and backgrounds for them to create friendships in order to combat social isolation. And this has been extremely rewarding. So if you're interested in this, you guys can visit our Instagram where we have been documenting it, and you can really see the impact that it has had.
Thank you. And feel free to throw that Instagram link in the chat here so people can follow you. So quickly, we have some questions that I'm going to go ahead and ask of the panelists as we go through here. But for those of you who are participating today, we want to hear your questions as well. So for those of you that are Zoom veterans, there's a Q&A function along the bottom of the screen. If you click in there, that's the best place to put questions as opposed to the chat. But honestly, that's I think we can probably get to your questions either way. But go ahead and start putting your questions in the chat, and we will get to them after we get through our prepared questions. But I want to start with this, and this is a question for Amy. Amy, one of the scenarios we just went over briefly mentions the challenges of accessing paid in-home care in rural areas. Can you share a bit more about the challenges older adults are facing in accessing in-home care in Southwest Colorado and some of the reasons why?
Yeah, absolutely, Chris. What part of our area is the west end of Montrose County, which is about 2 hours from Montrose proper. We have one home care agency that will serve, it's about probably 2,000 square miles. And so there's challenges in supporting that organization because there are workforce shortages. So we have a limited pool of trained caregivers in those areas. And a lot of the caregivers don't want to travel more than 20 or so miles. Medicaid reimbursement doesn't pay mileage. And so between the low wages and lack of mileage reimbursement, it's hard to get people to travel, even 30 miles to provide that care. A lot of our older adults are geographically isolated. So they may have a caregiver that might be a daughter that's working full time and is also taking care of her kids or his kids. And so the lack of transportation possibly also creates that barrier. It also creates the barrier for the caregivers to be able to get the person they're caring for to medical appointments. The transportation barriers we're seeing right now in San Miguel County and the west end of Montrose County is, we have older adults and caregivers who aren't able to drive 2 hours to get to a specialty appointment. And so we're finding that caregivers are getting burnt out because they're not able to get the care that they need for the person that they're caring for. We're also seeing the economic barriers to caregiving, especially, in some of our areas, we have a frontier area, and then in part of that area, we have a ski resort. And so to pay a caregiver $20 an hour when they can make $35 an hour cleaning hotel rooms, it puts that economic barrier. And then there's also the insufficient funds for Medicaid reimbursement. And so some providers aren't accepting Medicaid, they can get paid more as a private caregiver. And then the other issue that we're seeing is just having and helping our community members navigate the complex systems that we have. Applying for a long-term care waiver program and navigating the eligibility system and the paperwork that's needed for the Medicaid waiver. And we have, some older adults don't have computers, or there might be literacy, or there's language barriers. And so helping navigate these complex systems is vital to keeping people in their homes and also supporting those caregivers. And then the last thing that we're seeing is, there's stigma and there's lack of awareness. And so in some of our rural communities, people don't want people coming into their homes. And so they're going without those services and struggling because of that pride and that dignity and not wanting to have, somebody that they don't know coming into their home. And then also just the lack of awareness. There are programs that are available, but with the rural areas, it's hard for people to navigate that. And you don't know what you don't know until you need it. And then we're really focusing on that awareness piece and meeting with people and going over what programs and services are available if they need it. So not waiting for a crisis to happen. Let's get awareness out there sooner than later.
That's really interesting, Amy. So on the last couple of points you're making, I'm curious what this has meant for the outcomes for older adults and what they are doing to take care of themselves when these other resources are not available.
Yeah, it's really when the other resources aren't available, it's really increasing the burden on the caregivers. We are seeing, with the unpaid caregiving that's happening, we're seeing a lot of burnout. We are also seeing that, you think it's easy to take care of an older adult, right? But you don't know how to maybe transfer. And so not knowing how to adequately care for someone also leads to health decline. It leads to, improper care, which may lead to institutional care. I met with a family the other day, and, they were trying to lift their older adult from a chair into a wheelchair, and they were picking them up underneath their arms. And this is a frail older adult. And, using things like a gait belt, you don't know how to take care of people. So people with their best intentions are trying to provide this care, but they don't know how to do it adequately.
Yeah, big challenges. So Mia, turning to you, one of the questions I'm curious about is what does care for older adults in your work and in the communities you serve look like, and how do unpaid caregivers play a role?
Yes. So, because of certain barriers like legal status or language barriers or lack of accessibility or a mix of all of these, access to care is extremely limited. For example, through the cohort made up of Latinas that I help run, I have heard countless stories from participants expressing urgent need for medical care, but either for one reason or another, they can't access it. It might be that their legal status gets in the way of them getting health insurance, but then paying for it out of pocket is too expensive. But then on top of that, they might not be comfortable using technology, so they can't find resources themselves to help them. And so this list of things sort of tells a story of how difficult it can be to access care as an older adult who is living in poverty and dealing with not only cultural and systemic barriers, but the stigma that getting outside help carries because so many Latinas feel pressure to sort of pull themselves up by the bootstraps, or they feel the pressure of not living up to the American dream. And even though this is extremely outdated and there should be no shame in receiving help, it is a reality that we face. And something that I saw during the focus group as well, that I helped run in collaboration with Bell Policy, is that unpaid caregiving means that you have to access care for two or more people all by yourself. So, as a caregiver, you carry the burden of making sure that all the needs of all the people that you care for are met. And so, these barriers are just multiplied as an unpaid caregiver. And so, if you want to access mental health services or physical care or other resources like food banks, you do have to rely on making connections with the community and receiving information from word of mouth and trusting your family and friends for recommendations because this is how you build trust. But unfortunately, this is not always the most effective way to look for and receive help. So it can be extremely difficult, which is very unfortunate.
Yeah, yeah. So sticking with you, Mia, one of the findings of this project is the hidden cost of unpaid caregiving. What are some of the long-term physical, emotional, and financial impacts that caregivers experience when they're providing care without compensation?
So I see physical and emotional impacts going hand in hand, especially for Latinas. Since according to a report from AARP on caregiving, caregivers experience higher rates of stress, anxiety, and depression. So 40 to 70% of caregivers experience depression in comparison to 7% of the general population. And on top of that, they experience more fatigue than white caregivers. So being in these highly stressful situations, it can really affect their mental health and in turn affect their physical health because they tend to neglect their own needs. Research also shows that Latinas fill caregiving positions more often than any other racial group, and sometimes they're forced into these roles because they're more likely to live in multi-generational households. So caregivers who don't feel like they have a choice in their caregiving responsibilities are more likely to face increased stress and strain. And as for financial outcomes, we see caregivers spending a lot of their own savings to meet other people's needs, whether it's basic needs like food or transportation, or going above and beyond and getting certified in certain procedures like administrating vaccines. This is also a cost that they have to pay for. And again, uncertainty is a big source of anxiety since the kinds of care that people need are getting increasingly more complex, which means more doctor visits and more expenses that they have to take care of.
So how do they deal with these stresses? I mean, what do the caregivers in these communities do, and where do they seek support, and what's available to them?
So something that I have seen that is really helpful, again, in the social group that I help run, a lot of Latinas are caregivers. And so I do see the change and the impact that has had on them, being part of these groups. You would be surprised how often they get excited to just share about the experiences. So it's not a burden that they have to carry themselves. Sometimes social interactions are a bit superficial, like day-to-day interactions with your family, your friends. And so finding a space like this where you can vent and maybe go a little bit deeper in the struggles that you are facing, I have seen is really therapeutic for them.
Thank you. So, Perrine, stepping back up to 30,000 feet and thinking about the broader implications, how do these costs that we're seeing in this model compare to the current public investment the state is making in caregiving?
Yeah, so when thinking about in-home caregiving for older adults, sort of the main funding that exists currently to support that is through Medicaid. Thinking about sort of the home and community-based service waivers that are available. There also is funding, of course, through AAAs that help support some of that care. But really, and of course, not everyone who needs care, when we're sort of looking at these costs from the model, not everyone who needs care will be eligible for these like Medicaid waivers, for example, and that's important to keep in mind. But when we look at the Medicaid reimbursement rate for personal care outside of Denver County, it's about $28 is the hourly reimbursement rate. And when you look at supporting caregivers, again, with that self-sufficient wage, for example, an hour of paid care is actually more like $56 an hour. So that's almost double. The cost of doing that is double if we wanted to pay these living wages and robust benefits from what we're currently investing in, specifically in Medicaid reimbursement rates. And then, that's not to say that supporting paid caregivers is too costly or unattainable, but I think just rather really highlights how undervalued that work really is at the moment. And then thinking about the unpaid side, that the current public investment that we see for unpaid care is a bit more sparse. There is a small home modification tax credit that exists, and some support for unpaid caregivers in accessing respite care. Again, those investments are pretty small. They total to around, I think, 3 million, which that is a big number, but in the scheme of things, 3 million is a small amount of support for unpaid caregiving. When you look at the model again, where we see most care being provided by unpaid caregivers and looking at the costs that they will incur is closer to $4 billion, which is just a large difference. And the large majority of that is coming from lost wages, for example. And I think here there are a lot of questions to explore in thinking about who pays, and it's not necessarily to say that, the state needs to invest $4 billion, but rather, if we know that a lot of this is coming from lost wages, what are some other sort of policy interventions or strategies that we can think about to sort of help ease that? Or if we know that there are these large financial costs when you think about out-of-pocket costs or equipment and getting transportation, et cetera, all of these things that both Amy and Mia mentioned, where might be the financial support that is helpful in easing some of those challenges?
Yeah. So, we think about the fairly large numbers that are in here about what it would take to fully support this workforce, but resources are always scarce. And so it often comes down to a question of identifying the most urgent needs and the places where an investment can make the biggest difference. So Amy and Mia, what I'm curious about is, of all the needs that we've been talking about today, which ones do you think are the greatest? And where do you think the cost model can help us identify top priorities for investment?
Yeah, I can go. I think one of the greatest needs that we are seeing right now is the caregiver shortage for paid caregivers, which is leading to more of the unpaid caregivers needing to step in. I think, the competitive wages, that Perrine was just talking about is crucial to get qualified people in those caregiving roles. I mean, we're seeing it in home care. We're also seeing it in home health. The hospital systems are also, struggling with keeping caregivers in the workforce. So to me, a crucial area right now is workforce development and retention.
So I am a big proponent of direct cash assistance since caregiving is an area that we don't invest enough in. And actually, according to the CDC, at any given moment, an average of 25% of all Americans over the age of 45 are taking care of a friend or loved one due to a medical concern or disability. And this period of caregiving makes up of an average of 20 hours a week. And on top of that, only 1 in 4 caregivers report requesting or applying for financial assistance. So I think a lot of their needs and problems can be solved by just giving them money. There's actually been a couple of pilots for direct cash assistance across the US, and they have collected data on how their money is spent and the outcomes of it. And the data shows that they spent the money on basic needs like transportation, food, um, paying for a car to even get to doctor's appointments. So these people really know how to manage their money. And then when you look at the recorded outcomes, you can see how much of a lifeline this is for them. And the populations that these pilots tend to serve are POC or like single moms, for example. So it shows how difficult it is to care for someone financially and how no matter how hard you try or how hard you work, because of all the systemic and cultural barriers that we face, it's extremely hard to get your basic needs met, and it's extremely hard to be a successful caregiver. So I feel like investing into direct cash assistance um, is the way to go, really.
Thank you. So let's go to a question from one of our participants today. So have we been able to identify state or local resources to help with workforce recruitment, training, or self-care? And are there initiatives underway?
Yeah, so I can start, but I also would love to hear from Amy, who might be aware of some more local initiatives that might be happening. But especially in thinking about sort of some of those state resources in terms of training and recruitment, there definitely is a lot of energy and effort happening there from the state, both at HCPF, thinking about there's the direct care collaborative, the direct care workforce collaborative that works a lot on both thinking about compensation, thinking about training and benefits, and how this can all be implemented for caregivers, for older adults and beyond older adults as well. There was legislation passed a couple years ago, the Direct Care Workforce Stabilization Board. So that's another effort at the state, really digging into what those needs are, how we might be able to, better, increase pay and recruit workers and what those main challenges look like. So there definitely is, there are many initiatives sort of underway looking at that. And I think funding is, the funding streams is really like the tricky part, and actually being able to come through with those increased wages and thinking about those increased Medicaid reimbursement rates, which are so important to the pay that caregivers are receiving. And I would also note that there are like local nonprofits and organizations, even thinking about organizations like the Alzheimer's Association that are providing resources to caregivers, to unpaid caregivers as well. But these are really dependent, all of these are sort of dependent on the place that you're in and where you're at, and are a bit more disjointed in some ways, in terms of actually getting these benefits to people. But there are certainly a lot of initiatives that are happening, and great resources that are coming from the state as well that are working towards increasing recruitment.
Yeah, we're working with our local area agency on aging, and looking at being creative in, providing a consumer directed approach, kind of what you were saying, me, about those cash assistants. So we're working with people that don't quite qualify for a long-term care waiver, but they still need help at home. And they have a family member or a neighbor that is helping them. Through the consumer directed program, the area agency on aging is able to put in funds to help pay for that caregiving, which is great. And we're working on trying to find other funding sources to help with those payments. We're also having conversations with PICPUF and the workforce. I actually think Brooke is on this call, in developing, more of a workforce. And so it's going to take all of us working together to, takes a village, right, to take care of people. And so at the state level and at the local level, I think having those conversations, and continuing to have those conversations is going to be crucial, which is why I'm so grateful for the Bell policy and what you guys have done around the cost of caregiving, because this is great conversation.
Thank you. So to everyone on the call, we do have time for a few more questions, so feel free to throw more questions in the chat. One question I will ask is, what does this mean for the long term? I mean, we're talking about these gaps that we have, but what happens if we fail to adequately invest in these supports as Colorado's population continues to age?
I think if we don't come up with a solution to help people age in place and remain at home, the lack of caregiving, people's health is going to decline. We already see ER visits on the rise. Facilities, skilled nursing facilities are already full. So I think you're going to have an increase in adult protective cases, because people aren't getting the care that they need.
I would just go ahead, Mia, sorry.
I just wanted to quickly add that on top of what Amy said, I feel like if we don't adequately invest, it's sort of sending a message to the greater society that it's okay to treat caregivers this way, even though it's not. So I feel like we have to set a better example for future generations and show that even though they're not officially recognized as people from the working force, they do deserve to be adequately compensated, adequately taken care of, etc.
One thing that I was just going to add to what Amy was saying is, especially as we think about sort of the costs at the state level, and just thinking about providing that in-home care, is if that's not accessible, in some cases, people will go to those nursing care facilities, which actually are more costly. And so it's sort of thinking about how, one, in-home care is preferred for many older adults. So that is an important thing to take into consideration. But additionally, if people are able to access that care, we're sort of, in some ways, avoiding them going to a more costly nursing facility before they have to, for example. And the other thing that I would sort of note about not investing, if we don't make these sort of investments, those costs don't disappear, right? They're just being shouldered by unpaid caregivers, like Mia was saying, who are the family members and friends who are providing care, in some cases at the expense of their own well-being as well. And so seeing their health impacts continue to decline, and how that impacts their financial well-being down the line as well.
Thank you. So I think we have time for probably one more question. And so I think let's just end on this note. I mean, what do we do to raise awareness and continue driving this conversation forward so that it becomes clear to a greater number of people, maybe those who have not yet thought about what this looks like for their own aging parents? How do we raise awareness and continue getting some momentum on solving these problems?
I think I'll just shout out both Tri-County Health Network and Claro, who are doing so much work in their communities. And I'm, thinking about the groups of older adults that Claro is getting together and having these conversations, and sort of the relationships that Tri-County Health Network has throughout their region in Southwest Colorado, and having these conversations with people is really important. Thinking about what Amy was saying earlier about stigma, and ensuring that people are having these conversations. And I also think that this is important information and conversations to be having with people at the state, who also really care about providing care for older adults, and who are also working for these sort of same goals. And so I think really facilitating these conversations across the state, but also within community, is really important.
Thank you. Anything to add, Mia or Amy?
No, I completely agree with what Perrine said. We have to keep having conversations, and the conversations need to rise to levels where the systems can be improved.
Yes, I was going to say culturally competent knowledge sharing in these communities. It's so important to have them be part of this conversation. And once we show them that we are trustworthy and they can open up to us and they become vulnerable with us, then I think we can start problem solving from there.
Thank you. All right. Well, as we approach the end of the hour here, I just want to say again, thank you so much to Perrine, Amy, and Mia for all of your hard work and your collaboration on figuring out a way to move forward on a really, really challenging issue. Perrine, I'm not sure if you had more to say in wrap up here, or if I'm just the wrapper upper today.
I'll just quickly add, just that as you are all using the model, please feel free to email me with like feedback. We definitely want to hear the feedback as you're using the model. Again, as I said, we want to be able to add to the model as down the line. And so just as you're using it and thinking about, hey, this would be helpful to have in the model, please feel free to reach out, one with questions, but also just with any feedback you have. And then I'll pass it back to you to finish the wrap up, Chris.
All right. Sounds good. Thank you so much, Perrine. All of you are now seeing the closing slide here. We wanted to just promote one more thing. For the Bell's end of the year event, we're doing a kind of fun and lighthearted gathering on the evening of December 4th at Chaluna Brewing at Stanley Marketplace. We're doing a Celebrity Jeopardy theme. We've got a couple of our panelists featured here that you can look at, but we'll post a link in the chat right here so you guys can see. Let's see. So you can RSVP for the event. It's not you don't have to pay to attend. I mean, we are, like every good nonprofit, always fundraising, but really we just want to see your faces there. So please come join us for a fun evening to celebrate the end of the year and start gearing up for the hard work that lies ahead. So thank you again. Thanks to Perrine, Amy, and Mia, and thanks to all of you for giving us an hour of your time today to dig into this cost model.